And we now quickly move on to our next big session, the journey with legends. Interviews with legends in the field of spine surgery. Today we have got three great legends. The starts with Professor Stefano Boriani from Italy, who is going to be interviewed by Dr. K. Venkatesh from the CMC Vellore. That is going to be followed by an interview with Dr. Michael Failings from Canada, and he is going to be interviewed by Dr. Rohit Amaritanand, who is again from CMC Vellore. And the final talk in this session, the interview, is going to be with two legends of India, the people who described what is called as the Harms Goel technique, but which is actually the Goel-Lahiri technique originally. And that is, we have both these gentlemen, Dr. Vijay Lahiri and Dr. Atul Goel, and they are going to be interviewed by their student and a very dynamic spine surgeon, Dr. Samir Dalvi. So without wasting any more time, let us have the first interview. Sushil, can you place the interview of Dr. Boriani?
So good evening, everyone. And it gives me indeed a great privilege to welcome Professor Boriani, who is a doyen of spine tumor surgery. He doesn't need any major introduction. In fact, no introduction at all. Everybody knows about him, but still, as a routine, I will say that he's a very senior orthopedic surgeon from Italy. So after finishing his specialization in orthopedics, so he worked at the Rizzoli Institute with Professor Mario Campanazzi in the subunit of oncologic spine surgery. So after that, he has held many prestigious positions, and currently he is the director of spinal teaching program and the head of spine tumor surgery in the spine surgery division at the Galeazzi Institute at Milan. So Professor Boriani has more than 430 articles which are in the peer-reviewed scientific journals. He has conducted many programs and courses, and he is the chairman of the Module 3 and the master course of the European Spine Foundation. He has authored many textbooks, and he has 9 monographies to his academic bank. He has been a visiting professor for more than at least 14 major universities, which includes the Harvard Medical School. And Professor Boriani, I would like to welcome you for the annual conference of the Association of Spine Surgeons of India, and which is being conducted virtual this time because of the corona pandemic. So welcome, Professor Boriani.
Thank you very much. Thank you. It's a very great privilege for me. Thank you very much for this invitation.
So to start with, most of us like spine surgeons, most of us try to avoid doing spine tumor work. So it's a very challenging issue. So, but how have you taken interest in doing spine tumor surgery as your exclusive work? And when most of us think that we have to move away from it and do the other works. So what made you to get such an interest in this field?
Thank you very much for this question. And let me know that it's really a great privilege for me to be here and to be invited to you. And let me try to give an answer to this question, just to show my slide and introduce by imaging what I want to tell you. So first of all, on the left, you can see Italy. And you can see that Bologna is here, just in the north part of Italy. Is not a big city, but it's a site where in 1896 was founded the Rizzoli Ortopedic Institute. It was the first orthopedic institution in Italy. And I was born in Bologna, and so I did the medical school in Bologna. And later on, I started as a student in 1976 to attend that Rizzoli Institute. And in this institution, most of more difficult cases, degenerative, but also tumoral, were referred since the beginning of the century. So at that time, more than 20,000 bone and soft tissue tumor cases, fully documented, were collected. And Professor Campanacci was my mentor, was working on this subject. He was a pathologist originally, and then he became an orthopedic surgeon. He became the director of the Rizzoli Institute, and he had the opportunity to study all this material and to write a lot of papers about new cases and a big book. He was a very famous pathologist on bone tumors. And he was the protagonist, together with Henneking, on the revolution of bone oncologists at that year. And there was really a great changing at that time. The combination of a new system to stage the tumor, this didn't exist before, together with the chemotherapy, the neoadjuvant chemotherapy, and the new surgical technique like en bloc resection, allowed to obtain great results in osteosarcoma of the limbs, for example, as the amputation went down to 95 to 5%, and the survival at 5 years raised up to 70%. So really great results. The question was, is this applicable to the spine? And this is a question that Professor Campanacci proposed me in a day of the spring of 1994. It was a day that changed my life. He called me in his office, and all of the other colleagues were working on the limbs, on joint replacement. I was the one dedicated to traumatology. And he told me, Stefano, why don't try to deepen the knowledge in bone tumors in the spine and give an answer to the question, are the criteria accepted for bone tumors in the limbs applicable to bone tumors in the spine? So this is really a great job. And it really changed completely my life. So first of all, I tried to study the spine. I didn't know anything about that. So I was a fellow in Paris at Rocamille, and in Marseille at the Louis Center, and in the States. And there was already some great surgeon working in bone tumors, but there were very few. The pioneer was Professor Steiner, that in the 70s, he was a general surgeon. So he started to apply to the spine what he was doing in the bowel. And so he described some very interesting case of en bloc resection. And you know that later on, Rocamille and later on Tomita popularized the technique of en bloc resection. But my idea was to create a complete and multifocal approaches to bone tumors, try to define the way to perform diagnosis and categorize the tumor according to staging, try to understand the biological behavior, and then decide the treatment according to that. So the first point was to translate the Henneking system, which was dedicated to the limb, to translate in the spine. And so we translate completely this technique, this system, which was previously dedicated in the limb. And so we found the indication to en bloc resection for aggressive benign tumor, for low-grade malignant, high-grade malignant when combined with chemotherapy. So it was a great job to try to organize all this activity. And so finally we arrived to perform the first en bloc resection in October 1991. This was the first vertebrectomy performed at Rizzoli, but I think also in Italy. It was a chordoma of L3. At the time I was at the age of 39. And we started with a posterior approach, removing all the healthy part of the vertebra, and then separating the dura from the posterior part of the vertebra, so separating from the tumor, starting the discectomy, and do the fixation. You could recognize the very old Isola system. And then we positioned the patient on the lateral side. We approached it from anterior, and we entered in the retroperitoneal cavity, and then combining anterior and posterior approach, once leaving the psoas over the tumor to have a good margin, we succeeded to resect and block this tumor. You see here the first specimen of a vertebrectomy. And we were quite happy. This patient survived for 8 years without any evidence of disease. And finally she died for another disease, but without any local recurrence. So it was the first time, was really successful. We were very happy. And so we went on studying and working on this subject. And since that time, I had the opportunity to collect, to observe and treat more than 2,000 cases, first at Rizzoli Institute, later in other 2 hospitals, in a great hospital in Bologna, and now at the Galeazzi Institute in Milano. So this is my career, which was mostly dedicated to bone tumors in the spine since the time that my mentor told me try to work on the subject.
It was wonderful, Professor Boriani. Actually, we have really explained us that what made you to take the interest, probably the great doyens you have worked with, especially Professor Campanese and with Anyking and all those people, has made you really a wonderful person in this field. But how was the evolution of this WBB classification? Because we considered it one of the gold standard. Okay, so how did it come into your mind? Like, what made you to think about this classification?
Thank you. It's really, so as I told you before, the idea was not only to perform surgeries, but to understand when to perform surgery, which kind of surgery to perform, how to standardize the approaches. And the idea was really to balance the aggressiveness of the surgery and maybe the combination with other treatment with the biological behavior of the tumor. So at the time, only one surgery was done for any kind of tumor, benign, malignant, metastasis. The idea was indeed to standardize, to stage. So stage means to create categories. And once that we have achieved the diagnosis, we have to understand the biological behavior of the histotype of the tumor, and this is the target of the Anyking staging system. But when we have to decide which kind of treatment, we need a system to stage the extension of the tumor. So this was the reason why it was really useful to have a relationship, a friendship with Jim Weinstein. You can see Jim Weinstein here on my slide?
Yes.
Okay, Jim Weinstein, you know, it's a very famous guy, is till now the editor-in-chief in Spine, but it is a great friend of mine. I was visiting him several times, he was visiting me. He had already the idea to stage the tumor extension. And this was his former system, which was a little bit complicated with different, with a coronal plane and the sagittal plane to divide the different part of the vertebra. Is the idea of the staging of the tumor is to have a better sharing of information among different groups, to file the database, and finally to plan the block resection. And so he accepted my idea to consider the tumor and the transverse section as a pie and to cut slides of the pie as we do on the tumor, on the vertebra. No? We have the center of the vertebra where there is the canal and the content of the canal, and then there is all the vertebra around, and all the surgery in the spine is limited by that problem. So that's the reason why I suggested this, and together with Biagini, you can see here was my fellow at the time, and so Weinstein, Boriani, and Biagini are here, and we proposed officially this system to the literature. And it really was a great success, as there is a lot of quotation, a lot of citation in the literature. And more recently, the SOSG, which is a society, a group of spine oncologists, spine surgeon oncologists, decide to understand, to assess the reliability of this system. And the conclusion was that it was reliable, but maybe it was better to rotate it in order to have it exactly like you see in an MRI or on the CT scan. It is the same, but just rotated to have a better view of the staging. And you see here the result. We had an inter-rater reliability in the group of 75% and intra-rater reliability about 90%, which is a very good result for a system. And since the time, most of the paper dedicated to tumor use this system, and really now they use even without cite the original paper, and this is means that it is a little bit entered in the mentality. And based on this system, we can plan the block resection. I wrote some years ago this paper proposing the application of the system to decide if it is better to perform only anterior approach, only posterior, or combination of anterior and posterior. So I think that this is, I think, the validity of the system today.
So like 2020 cases, it's a phenomenal number. So you must have seen a lot of cases and almost all variety of cases you must have seen. So can you share some of the challenging cases which you have encountered in your life?
So as I told you before, now I have the idea to show you two cases. So I can show how we plan and perform surgery. That I don't
so
think
you're going to start with the slide showing the on-block resection WBB system?
Yes.
Which was the last slide in the previous question?
Yeah, you can see, you see now?
Yeah.
Okay. So let's consider to have, we have different possibility. Obviously, when you have to perform a block resection, you must think in 3 dimensions. And you must imagine that there is a tumor and you must remove it with a good margin, with a shell of healthy tissue around it. So you must think in 3 dimensions and decide it better only anterior, only posterior, first anterior and then posterior, or different combination. So the idea is to define the criteria of feasibility. So for example, the combination of anterior first and posterior second is a good option, for example, for eccentrical cervical tumor. But we need that there is a part of the anterior of the vertebral body, sector 76 tumor-free. Obviously, we have to consider, if it is eccentric, to sacrifice nerve roots and the vertebral artery. Obviously, if the tumor is inside the canal, we have a high risk of contamination. And another criteria, very important, which is a basic criteria for having block resection, we need that at least 2 or 3 sectors in the posterior vertebra should be free of tumor. So let's see an example. With an example, everything is easier. So this is a recurrent chondrosarcoma in the cervical spine, C5 and C6. So you can see that is going from sector 11 to sector 8, okay? So we have sector 7, the sector 6, which are tumor-free, and the vertebral artery and nerve root will be sacrificed necessarily, otherwise we enter in the tumor, so they should be sacrificed to have a good margin. It's a Bilski 1, so the risk of contamination in the canal is very low. And a big 3 or 4 segment of the posterior elements are free, so we have a good access to the canal from posterior. So let's see how we perform. So first anterior approach, right anterolateral approach, and this allow us to do a typical release of a neurovascular bundle, but then we have to go all around the tumor without touching the tumor. So we have to leave muscles over the tumor mass, and then from posterior and anterior to have a very wide approach, as you can see here. And then we reach the anterior part of the vertebral body, and here we used an ultrasound scalpel to create a groove in the vertebral body, okay, reaching the canal. Then we can position as a bridge a plate, but we have not detached anything. It is still there, okay? And then we rotate the patient. You'll see what we have already done. A long posterior midline incision. So we can prepare the lamina from one side, but on the other side, we have to go over the muscle again, never seeing the tumor, and to touch where we have around from anterior part, where we have reached from the anterior part. Then we can do the laminectomy, enter in the canal, sacrifice the nerve root. You see here, these nerve roots must be sacrificed completely in order not to enter in the tumor. And then sacrificing the nerve root, we can displace the dural sac and arrive on the vertebral body and finalize the sagittal resection. You see here the sagittal resection, the posterior part, the posterior wall, and this is a huge tumor. You can imagine that the vertebral artery is some part here, and the nerve root have been cut inside here. So this is the specimen. You see that it is completely covered by tissue. Here the osteotomy. These are 3 vertebral body resected in block with a good anterior and posterior fusion. And this was a quite good result even from an oncological point of view, as we have a 5 years follow-up without any evidence of disease. Let me show quickly another case of combination of anterior and posterior approach, which is always a good idea when the tumor is growing anteriorly. If the tumor is growing anteriorly, you cannot go only by posterior, otherwise you enter in the tumor. So you must always remind that this is an oncological procedure. So we must first think to the tumor. We must remove the tumor, but covered by healthy tissue. So the criteria was fulfilled, for example, in this case, with the thoracic case, 4-5 levels. The sector involved are 9 to 5, layer A to C, okay? The canal is not involved. And one of the pedicle is free from tumor. So first we started with anterior approach, separating the aorta once that ligated and sacrificed the segmental vessels, and then the esophagus anteriorly. You see here that the pleura has been left over the tumor, and this is the aorta. And here you can see the chisel here and here that start the osteotomy from anterior above and below the tumor mass to have a good margin. Then we can go posterior and perform a wide laminectomy, as I showed before, sacrifice the nerve root, and finalize the en-bloc resection. You can see here, you can see the nerve root that has been sacrificed, the reconstruction with a cage and a rib. And you see here the 4-level en-bloc resection with the canal, and the tumor is still covered. It's very thin, but it is covered. And see here the CT scan. Here we had a problem in the reconstruction. Later on, maybe we can speak about problems, complications, that we have always some problem. If you don't think something, you are punished. For example, in this case, we have used a too thin cage anteriorly, so it was not a good anterior reconstruction. So we have a breakage of a rod. We doubled the rod, but it broke again after 6 years. And then we used a much stronger rod with some grafting. And hopefully, and thanks to God, we had 9-year follow-up without evidence of disease, with a stable situation. So it's a success from an oncological point of view. But the success is really connected with a good planning, which I think is the most important point.
Amazing, amazing cases, and it shows the master in action. Like seeing all these things, what would be your advice to the young spine surgeons who want to take up spine tumor as their career?
Well, as you told before, this is not easy. This is not an easy field of application. It's something that take you all the day in the operating room, all the day in the hospital, but especially also out of the hospital. You arrive at home and it remains in your mind. And if you have to plan a surgery like this, it takes a lot of time. And usually when I have a block resection, since the beginning, and even now, I spend 1 or 2 weeks always thinking to every step of the procedure. And so you have not even a time where you are free. So you must have a passion for that. And the passion should drive your work. And once you have this passion, it is a great satisfaction to do this difficult job, but you must be prepared to the complication that you can have, which are really very severe. And it is something that takes you so much. So I hope that there will be some young surgeon willing to take this road, and I am willing to help in any way if I can be helpful. But I think that if one has this passion, he should use this. He or she should use this passion to improve on this way.
I think that is the answer. Passion and dedication is the main thing which I think will But the problem is, when you have failures, especially in the spine tumor surgery, so you actually go back, like you climb 2 steps and then you go back by 4 steps or 5 steps when you have a failure. So how do you and especially these failures are quite common with spine tumor surgery. So how do you face the failures?
Well, failures are really a daily problem, as this surgery is so complicated, involved so many different organs, that you have to be prepared. But even if you are prepared, you have to suffer for that. And what is really the big limit, that even after so many years, you can have a different complication. As experience is not enough to prevent other mistake or even forgetting a small detail. And the small detail is something that brings you away. So if you want, I can show you one of my nightmares. And really something that has remained in my life. But I have, unfortunately, many cases where we had the problems. But the point is not only to have the problems, but to be able to solve it as soon as they arrive. This is, I hope you can see this, this slide. Yes, 61 years old, so a young man, but is a cardiovascular pathology is already present. He was a professor at the University of Milan, and he had some pain 6 months. And I saw him 13 years ago in 2007. So it's a small tumor, you see a lytic lesion with a good margin, and you see in the MRI that it's entering the canal. So it's not a big tumor, and it's very, very difficult to understand it is benign or this malignant. So we did a biopsy, and the biopsy result is low-grade malignant tumor, is low-grade central chondrosarcoma. And so the question is what to do. So sometimes there is people that in cases like this would like to do mini invasive surgery, or maybe wait if it grows, or only radiosurgery. There is now the willing to do maybe some local surgery and vertebroplasty, local mini invasive surgery, or intralesional excision, or finally a block resection. So we try to find an indication from the experience. This is what we do every time. And this is our collection at that time of chondrosarcoma in the spine was 47, 13 years ago. And from the experience we had till that time, that only en bloc resection with a good margin could guarantee a good result in terms of local recurrence and survival. You can see that all these patients submitted to en bloc resection with a good margin are survival, disease-free, with a maximum of 282 months, so more than 20 years. Otherwise, if we do mini invasive surgery or intralesion and radiation, maybe you can have some good result, but the rate is lower. So the indication to en bloc resection is evidence-based and should be performed every time is possible. So the limit is that sometimes an en bloc resection, even if relatively easy, like in this case, can have some surprise, and would like to show you. So for this case, it was a T12 tumor. You know that in T12, there are the attachment of the diaphragm. And so only by posterior approach, you can have problems to separate the diaphragm from the vertebra. So the idea was to do first an anterior approach. You can see here, we have done the discectomy here and here. We have already released the diaphragm. And then by posterior approach, we do the typical Rockamillo Tomita technique at this point with this malleable retractor that go around the vertebral body. And then we separated the dural sac from the vertebral body, ligating the nerve roots, disc section, and this is a block resection. So everybody's happy. As we did the block resection, there is a good margin. The tumor has never been touched. But to achieve that, We had a very profuse bleeding. The patient was very difficult to keep a good balance, cardiovascular balance. It was 10-hour surgery with 3 liters of blood loss. And so after 2 days, they called me during the night in the hospital, and the patient was experiencing some motor weakness. Is 1 on 5 on the left, 3 on 5 on the right. So I opened the surgical room in the night, and we have evacuated, removed the hematoma with a good recovering of motor function. But after 7 days, there was a urinary infection with a very high fever. And so we started antibiotic treatment, but didn't prevent from a systemic sepsis. After 14 days from surgery, you can see here a collection of purulent liquid around the vertebral resection site. So really a disaster, as the patient was a sepsis with the problems in moving the legs. And so we did a drainage of the purulent cavity, 200 cc, and we had a small improving of the situation. But after a few days, there was another worsening of the general status with the paraplegic. So we bring the patient again in the operating room. We did a debridement. We removed the stackable cage. We replaced with a titanium cage filled with gentamicin beads. We found that there was also a dural lesion, and so we had to repair it. And then we go on with antibiotic culture-guided treatment with a lot of antibiotic after isolating Escherichia coli and Staphylococcus aureus. And so looked like a little bit better, but 1 week later, again, paraplegic and worsening of the general status and purulent liquid coming out even from the anterior incision. So you can imagine the disaster. You can imagine that in all these days, it was very difficult for me to sleep. I had only this in my mind. So it was very, very difficult to consider which doing different. And it was still leaking of the liquid even after the 3rd surgical revision. So we did another debridement from both wounds, anterior and posterior. We did another repair as the dura was really breaking as soon as we were touching. And we put also some tobramycin beads. You can see here the CSF that is coming out together with the liquid. So we put some tobramycin beads locally. And this was the post-operative picture after this time. So hopefully after 4 revision and after weeks of antibiotic treatment, things were going a little bit better. There was a neurological slow improvement and no clinical sign of infection. You see here that the cage is still stable together with troposidin beads. And I can tell you that after 2 years, the situation was not so bad. The patient had some sagittal imbalance, but it was he was back to full activity, was working as a professor. The pain was very well controlled. It's not an excellent result, but it was not died and was still working. What is the story later? He had a myocardial infarction in 2013, so 5 years after the surgery, which limited the activity. And after 3 years, in October 16, it means 8 years after the vertebrectomy, he had a recurrence of the local infection. It is really unbelievable, but it's really what unexpected situation. It was impossible to do anything due to the cardiovascular problem, and he died for a cardiovascular disease in January 17, so 9 years after the block resection. So this is what we can expect in this kind of surgery, that even if you try to do all the best you can do, but you can have infection, cardiovascular problem, and obviously the compression on the dural sac. So really, really difficult, and difficult to find in the literature as how you can describe this case. Every case is different, and every disaster is different. But if you want to work in this subject, you must be prepared to have cases like this.
I think you should be really hard in your, strong in your heart and mind to face all these conditions.
Yes.
So how do you manage your work-life balance? Because it seems that most of the time you are in the hospital.
I have already given the answer. The answer is that you have not anymore your private life, as it's almost impossible, at least for me, it's impossible to separate my mind from these problems. So I arrive at home, and it's difficult that I can have another idea, have another thing. And you can imagine that now that I am close to thinking that I have to stop working before or later. We have a time that you should stop. But if I stop doing that, I don't know what to do, as I have no hobby. All my life was concentrated only in this activity. And so I cannot go fishing. I cannot go golf. I cannot do anything else than prepare a slide for you, for example.
Amazing, Professor. Amazing. You have dedicated your whole life for this surgeries, and which has brought us so much of activity in us. Like, we can do so much on seeing you and learning from you. So thank you very much, Professor Boriani, for taking your time. And I hope there'll be a lot of questions from the audience. And I would like you to answer those questions if you can. Thank you very much, Professor Boriani.
Thank you very much. It was really a great pleasure. Thank you very much for your question and for interest in my life. Thank you very much.
Thank you. Thank you very much.
Thank you, Dr. Boriani. This is Dr. Verma here. I would like to involve my co-moderator, Dr. Sajishman, if he's around. As people go on to start off questionnaire, can I start off with the first one? I'll start with something extracurricular. You said that for so many years, you've been doing such high intense work. All of us have something to wind up and stress buster. What do you use as your stress buster to go back to work the next day? Music? Anything that you do differently?
Yes, music. Music is always very helpful indeed. You're right. But
what about some exercises? Because the kind of time that you spend in the OR for hours together, how do you stay so fit? I mean,
yeah, I have never been so much dedicated to exercise. Only recently, I had to replace my left hip. And so I'm compelled now to exercise, to do bicycle every day. Otherwise, my hip is painful. So as a patient, I am better than as a surgeon.
The audience, the panelists, anybody with a question?
There are lots of questions from the audience. If you could stay around, and there will be on the chat box, and maybe you could answer some questions over there.